Hello, everyone, and welcome to ADA's 2023 Virtual Fall Forum on Sex and Anxiety. My name is Sasha Sakard, and I will be your moderator and host for today's program. Before we get started, I just want to be sure to go over a few technical details. This webinar is recorded and will be available on demand within 24 hours. For those who are joining us live and do require it, closed captioning is available and can be accessed at the bottom of your Zoom screen. For those who applied for CE credit, you will receive an email at the end of the session. Please note that we will be accepting questions throughout the session, but they will be answered at the end during our dedicated Q&A time. I would like to briefly go over our agenda for today's program. We have an amazing roster of speakers. We're going to start off with a keynote hosted by Dr. Andrew Rosen. Followed by a panel discussion and roundtable with our panelists, Dr. Mullen, Mr. Cohen, and Ms. Ajin. And then we will move into our audience Q&A. I would like to thank our presenters for being here and for sharing our time. I'd like to thank our attendees for joining us this morning and for spending the next 2 hours with us learning. We have Dr. Andrew Rosen joining us, Ms. Shaman Ajin, Mr. Larry Cohen, and Dr. Deborah Mullen. I would like to now welcome our keynote speaker, Dr. Andrew Rosen, who is a board-certified American Board of Professional Psychology. He is a board member of the National Social Anxiety Clinics. He is a clinical affiliate assistant professor at FAU Charles E. Schmidt College of Medicine. He is the co-founder of the Children's Center for Psychiatry, Psychology, and Related Services, as well as the founder of the Center for Treatment of Anxiety and Mood Disorders in Delray Beach, Florida, where he continues to serve as director and to work as a board-certified licensed psychologist providing in-person and telehealth treatment. Dr. Rosen, I'm going to hand it off to you. Everyone, thank you so much for joining us. Our panelists, we look forward to seeing you soon.
Good afternoon and good morning, depending upon where you are. I'd first like to thank ADA for asking me to do this presentation today on a topic that's really so essential in our work with patients and to try to help patients achieve a more rewarding and peaceful existence. It's quite a topic. Yesterday I was thinking, well, maybe it's too much of an uncomfortable topic for us to have with ADA. So for a minute, I thought about maybe changing the topic to discussing compulsive hand washing, but I quickly gave up that idea and I said, let's plow on and do this topic. Before we get into the topic, I'd just like to give you a little background about me so you know where I'm coming from with this whole issue. In 1975, I earned my PhD in clinical psych at Hofstra University, which was a really purely cognitive behavior program. And I was privileged to study under people like Arnold Lazarus and Albert Ellis, names from the past that really contributed a lot to the work we do today. After that, I decided I really did not know very much, and I then went on to study at the Gordon Derner Institute in New York, which is a psychoanalytic and psychotherapy certificate program, and I spent 6 years there. Interestingly, neither program really discussed or taught anything about sexual dysfunction.
Dr. Rosen,
Yes.
we want to share our screen?
Do I want to share the screen yet? Okay, let me.
Oh, I was just making sure.
Oh, not yet. I'll let you know. I'm sorry. So neither of these programs really discuss sexual dysfunction, and certainly in the psychoanalytic field, the understanding of sexual problems was based on conflict theory, and the idea was if you could help a person resolve their conflicts and their shame and guilt issues, whatever sexual problems existed would automatically kind of resolve. And so the only background or training I had in the area of sexual dysfunction was on my own. I studied a little bit of the Masters and Johnson work, which was a really tremendous amount of work in the field of sexual dysfunction. And then Helen Singer Kaplan, who was a pioneer psychiatrist who wrote many books and techniques on sexual dysfunction. At any rate, nobody really talked much about it. And certainly nobody said to anybody, you know, make sure you ask the question of patients, how's your sex life? Nobody ever mentioned that. I moved to Florida in 1984 and founded the Center for the Treatment of Anxiety and Mood Disorders. And in 1988, I had the pleasure of going to my first ADAA meeting, which was at the time the Phobia Society of America. And it was there that I really found that there's a place to deal with and learn about anxiety disorders. Most of the workshops and talks were related to panic disorder and agoraphobia. I don't recall if there were any workshops that dealt with sexual dysfunction and anxiety. At any rate, I met Geraldine Ross there, and finally she came and gave some talks down in Florida, which were very impactful. But it was, again, based on panic disorder. In 1996, I was asked to write a chapter in a book, a textbook that was edited by Florence Kaslow, who's a well-known family oriented psychologist. And she asked me to write a chapter on anxiety disorders as they affect couples and families. Embarrassed to say, I only made one reference in the whole chapter to sexual dysfunction and anxiety, and it was one sentence basically about the role of social anxiety disorder and performance anxiety in sex. One sentence. And again, nobody ever really told me, or we never really talked about asking questions about sexuality. That we don't appreciate the importance of sex in our patients' lives. It's kind of based on the concept that Sherlock Holmes talked about, which was hiding things in plain sight. Sometimes things that are right in front of us, we don't notice. And I'm sure we all logically can sit here and say, well, of course, sex is important. Of course, a person and a couple's sex life is important. But that's the thing that's right in plain sight that we, for some reason, over the years, never really talked about. So there's three things I'd like to cover today, and then I'll get into my presentation. One is that sex has always been a neglected aspect of our patients' lives for many reasons, but we really need to help our patients and we need to help ourselves deal with it as a major component of life. Two, we must learn how to assess sexual dysfunction problems and how to treat it. Most of us don't know much about it. And three, for the future, our training programs, in whether it's in psychiatry, psychology, social work, marriage and family, mental health counseling, need to have that as sexual dysfunction as a significant part of the training programs, not just maybe a week or two of discussion about it, but 1 or 2 courses to teach new clinicians about this topic. Okay, Sasha, we can go to my slides now. Okay, I'd like to start with this. I hope everybody can see who's in the background of this.
We
But
cannot.
for those of you who have not seen the movie ever, it's a classic by Bob.
Hi, the slides are on the screen.
And this is a quote from the movie where Bill Murray, who plays Bob Wiley, who's a very, very anxious patient.
Dr. Rosen,
Yes.
we don't see the slides.
You don't see the slide? You're not seeing it?
We are not.
Okay, 1 second, then I have to go back.
Here we go.
Okay. Now good?
All good.
Okay. So Bob Wiley, who's this very, very anxious patient, is telling a joke to the psychiatric staff there. And the joke is the doctor draws 2 circles and asks the patient, what do you see? And the patient says sex. So the doctor draws a tree and says, what do you see? And the patient says sex. So now the doctor draws a car and then an owl and says, what do you see? And the patient says sex, sex, sex. So the doctor says, you're obsessed with sex. And the patient says, you're the one who's showing me all these dirty pictures. And I think that kind of says a lot about what goes on in the interaction between therapist and patient sometimes. Really kind of like nobody really wants to own it. and it just gets passed back and forth like a ping pong ball. For those who haven't seen the movie, it's a must for any mental health clinician. It's funny. So this is what I want to make sure that, 1 second. There's a part of our understanding. Sexuality is an essential part of being human. Love, affection, and sexual intimacy contribute to healthy relationships and individual happiness. However, along the way, positive aspects of our human sexuality, there are other things that happen, like physical illnesses and negative emotions and unintended consequences that can affect our sex life. And this is the central issue here, that it is an important part of our happiness and our existence as human beings. And there are things along the way that can impact it. One of those things that we know about is anxiety. So a little history on where we were in terms of our last several centuries, in terms of how the approach in dealing with sexuality might impact on our present day clinical work. Greek and Roman times, things like they believed that penetration was proof of manhood. Plato believed that sexuality was an irrational frenzy and was purely for procreation. Philosophers then got involved and talked about sexual desire as being wrong. And in the 19th century, there was a shift towards seeing sexuality as a topic that was distasteful, and still morality prevailed. When we got to the 20th century, there was an improvement, so to speak, and there was a shift from moral issues to psychological ones, brought about primarily by psychoanalysis and Freud, and things like castration anxiety were discussed. And most mental illness was seen as caused by sexual problems. Masters and Johnson came along in the second half of the century and provided a tremendous amount of actually empirical data about sexual response. But still, Lucy and Ricky Ricardo still slept in separate beds. And when we got to the 21st century, things really moved along, and sexuality was much more focused on from a physiological and a biochemistry standpoint, and medicines like Viagra became the prevailing form of treatment for many sexual problems. And for women, the history of sexuality was a little different, but basically, if we follow along between the earlier centuries that I've listed here, women were not really to partake in sex other than for procreation, and it would only occur within the context of marriage. And if it didn't, they were viewed as negative in certain ways. In the late 19th century, early 20th century, Freud postulated that most forms of mental illness in women are caused by sexual frustration. And he talked about two types of orgasms. In the 20th century, we moved forward so that sexual satisfaction in women became more of an issue and more important than repression or limitation or abstinence. And again, Masters and Johnson had a lot of impact on how we perceive sexuality in women. But still, Ralph and Alice Cramden slept in separate beds. 21st century, there's again a shift so that we have much more of a scientific understanding of female sexuality, and viewed female sexuality as generally considered to be more complex than men's. So this history is important in terms of understanding why we still are so backwards in most cases in dealing with sexuality with our patients. So where we are now, well, pretty much my little snippet on the bottom was due to snoring and sleep apnea. Not only do we not sleep in the same bed, we don't even sleep in the same room anymore. And that's a problem. But we don't ask that much. And here's some cartoons that demonstrate maybe what some of our patients are saying. And in case you can't read it, in the top left one, the woman is saying, perhaps your performance anxiety wouldn't be as bad if you perform better. And the middle slide, it's the uptight medical clinic where we treat the whole person except the sexual stuff. And the one on the right, you can see the person is saying that was a satisfying tweet. Bottom left, believe me, you're just thinking about it too much. It looks like the thinker there. And then the final slide, I ride a Harley, I drive a Porsche, I smoke cigars, I drink martinis. And the shrink says, so you're impotent, hey? So these are the patients, so to speak, that are out there, and the ones that we will be addressing. At any rate, mental health treatment and sexuality still in mental health and medical professions still do not fully recognize that sexual problems can lead to or contribute to depression, anxiety, eating disorders, trauma, and substance abuse. Conversely, mental health and medical professionals rarely discuss the effect that these disorders have upon patients' sexuality. And that is the thing I'd like to us to take away from this talk today, is that needs to change. Peter Pan said, the moment you doubt whether you can fly, you cease forever to be able to do it. And doubt is what anxiety is all about, and doubt is what impacts on our patients' sexual lives, doubt. So Peter Pan was very profound with that statement. Another important concept that we need to pay attention to and really let our patients know when it comes to sexuality is that when a person is involved with battle or threat of any kind, the survival instinct understands that this is not the time for passion. This is not the time for dining. It's not the time for reading. And it's not the time for pleasure. This is the time to watch out and defend oneself. And that is the dynamic that occurs one way or the other, where there's an interface with anxiety and the sexual response. This isn't the time to enjoy sex. This is not the time to focus in on sensations. This is the time for your brain to figure out how to protect yourself. And that's the thing I find it imperative to explain to patients. And partly that helps patients see it as a normal response that they're having, except that there is no danger except what their thoughts are telling them. It takes away from some of the shame and the embarrassment and the stigma that one has when one feels like they can't perform sexually. Interestingly, if we have the list that we know about of the most common reasons why there's marital conflict, on the top of the list, the first two are finances and sex problems. And then we go down the list to careers, problems with children, not doing chores. And yet, therapists rarely discuss sex or money. Patients very rarely want to tell me how much money they have, whether they have a little of it or they have a lot of it. And at the same level, they have a very hard time telling us about whether they have a sex problem. We just assume, in many respects, that they're having a normal sex life, even if they're having panic, even if they're having social anxiety, even if they're having OCD, even if we just kind of assume that back there is a sex life. Interestingly, also, if we think about the benefits of sex, here's a list. Improves immune system, can lower blood pressure, burns calories and reduces risk of heart disease. It helps reduce stress and anxiety and improves depression and sleep. Improves bladder control and reduces incidence of prostate disease and maybe even cancer. Improves self-esteem and improves relationships. You would think that if we can help patients with their sex lives, this would have dramatic impact on all these other things, which is what we're trying to help our patients do, have a better life and a healthier life. But we don't talk about sex much. But we do talk about overcoming phobias like flying, elevators, bridges, public speaking, snakes and spiders, and driving. We talk a lot about that. And also white coat syndrome, being able to go to the doctor with less anxiety so that your blood pressure is not high. Now, all of these things are important, but clearly they have much less benefit to a person's life overall than sex. Yet we don't focus on it. Very interesting. So the question is, why do clinicians not spend much time, if any time, asking about or talking about sex with their patients unless the patient brings it up? And generally, that's when a patient may be going to see a sex therapist. They've identified to have the problem and they go to the sex therapist. So it's okay to talk about it. But if they're coming to a clinician to talk about their anxiety problems, they may never bring this up. And therefore, it's important for the clinician to do that. But here's some reasons why we don't. First of all, there's a serious lack of training, which I mentioned before. Most programs, education programs, whether it be in psychiatry, psychology, mental health, social work, they either don't mention sexual dysfunction or they may discuss it in a half of a semester or a quarter of a semester, but it's never a significant part of the agenda in the 3 or 4 or 2 years of training that a person goes through. So if you don't get training in it, that means you don't get skills to deal with it and you have no information to deal with it. So the clinician doesn't feel effective. They don't have that efficacy. And we all know if we don't feel like we're good at something and we don't understand something or we don't have information, we tend to avoid it. Other issues might be the religious background of the clinician that maybe affect whether or not it feels okay to ask questions about sex. And with the zeitgeist today of, fears of everybody being wrongly accused or wrongly judged for things, definitely today, I think clinicians are kind of worried about asking questions about sex because they're maybe fearful that it might be misconstrued as something else. Also, the therapist's own experiences in life, there's data that suggests that many therapists have had a history of either sexual abuse or some kind of trauma. Now, that will have an impact also on the comfort level of the clinician in talking about this kind of stuff. And then who doesn't have issues related to shame and embarrassment? So that also can have an impact on whether or not we're going to go there and talk to our patients about this. So now I'd like to move towards, learning a lot more about sexual dysfunction per se. The first part was to deal with the fact that there's a paucity of education and a lack of experience in the clinical room in talking about sex. But now let's get some education about sexual dysfunction. According to DSM-3, the symptoms of sexual dysfunction have to have persisted for at least 6 months, and symptoms have to be causing a significant level of distress in the person's life. It can't just be a once in a while intermittent unhappy sexual experience, and it needs to also have the characteristic of contributing significant distress in the person's life, and also not caused or explained better by some other disorder. Okay, so defining characteristics of sexual disorders. Let me go through some of that with you. The diagnosis of delayed ejaculation has to be either delayed or absent 75 to 100% of the time. That's a lot. It's a high percentage. With erectile disorder, again, marked difficulty in obtaining or maintaining 75 to 100%. We have another diagnosis of female orgasmic disorder, where there's a marked delay or absence of orgasm 75 to 100% of the time. Female sexual interest arousal disorder, where there's a reduced interest or fantasy or initiation or receptivity for sexual experience. Another one is genitopelvic pain and penetration disorder, where there's a persistent and recurrent difficulty with penetration. We have male hypoactive sexual desire, where there's a reduced desire to engage in sexual encounters. Premature ejaculation, where there's a repetitive pattern of ejaculation within 1 minute of penetration. And then the final one is substance and medication-induced dysfunction that will impact and cause sexual dysfunction. The other characteristic that we consider when we diagnose sexual dysfunction is whether or not this is a lifelong experience, meaning it's present from the initial sexual experiences, whether it's acquired, meaning it's developed after a period of normal functioning, and whether or not it's generalized, where the person having sexual dysfunction in all types of situations or with certain or all kinds of partners or all kinds of situations of stimulation, or is it very situational? It's only happening in certain types of situations with certain types of people. So in terms of prevalence, this is really going to be, I think, surprise a lot of people how prevalent these disorders are. Erectile disorder, there's a strong age-related increase. And you can see that after age 50, it really increases to a huge percentage. Female orgasmic disorder, 10 to 42%, depending on the culture and severity and duration. And 10% of women have never had an orgasm in their whole lifetime. As far as female sexual interest and arousal disorder, it's a difficult one to get percentages about because if people have a hard time categorizing that and giving numbers to it. Genitopelvic pain and penetration, 15% of women. Male hypoactive sexual disorder, 6% in the young group, 18 to 24. And when we go 66 and up to 74, the studies show 41% of men have hyposexual desire. That's a huge number. That's basically half of men over age 66. Premature ejaculation disorder, depending upon who's putting the criteria to it, it's about 20 to 30% of men have this disorder. And in connection with substances and medications, 25 to 75% who are on certain medications will have sexual dysfunction. So here we talk about the effects of anxiety on sexual dysfunction. This is going this way on the street. And here we talk about anxiety plays an important role in the pathogenesis and maintenance of sexual dysfunction. Anxiety is seen as the final common pathway by which social, psychological, biological, and moral factors converge to impair the sexual response. We normally talk about the biopsychosocial model in terms of understanding all psychiatric problems, but in this one, it's definitely another category which we add into here, and that's the moral factor. And that definitely plays a role in sexual dysfunction. So if you look at numbers, this is a composite of many studies, anxiety is linked to about a 2.6 times greater incidence of orgasmic dysfunction. It's linked to about 2.1 greater risk of inhibited sexual dysfunction and a 3 times greater chance of decreased sexual desire. So if you have anxiety, there's a huge impact on sexuality, whether it be the actual performance, the desire, or the experience. In reverse, we have the effect of sexual dysfunction on anxiety. Negative sexual experiences obviously can create an anxiety response, like, uh-oh, what happened here? The anxiety response can lead to either or a cognitive response, like, what's wrong with me? Why did that happen? What's happening to me? What is that other person going to think? And so on and so forth. All of the what if statements and the catastrophic statements quickly. And also somatic results as well, high breathing rate, sweating, heart rate, any kind of sympathetic arousal. So the anxiety then leads to negative overthinking, which then leads to more sexual dysfunction. The what if thinking leads to more anxiety when entering into the sexual experience and clearly we know physiologically sympathetic arousal, the danger response, is incompatible with the pleasure response. So it's an automatic shutoff. And this cycle then leads to avoidance behavior. And the more avoidance there is, the more difficult it is to approach the feared situation the next time. And when the person approaches the feared situation the next time, the anxiety prevails, the sympathetic arousal comes on and interferes with the pleasure response. 1, 2, or 3 times of that, and people then start to really avoid the whole sexual experience with each other. So let me talk about the specific anxiety disorders and their incidence of sexual dysfunction. If you have generalized anxiety disorder, it's generally considered to be a 64% decrease in desire or involvement with sexual behavior. With panic disorder, 75% report sexual aversion or sexual arousal problems. With social anxiety disorder, in men, 30% report arousal or orgasm issue problems and ejaculation dysfunction. In women, 40% report desire dysfunction and or pain. With PTSD, 69% of people with PTSD report either erectile or orgasm dysfunction. And with OCD, sexual dysfunction ranges anywhere from 54 to 73%. Some of the prominent aspects of specific anxiety disorders and sexual dysfunction. With panic disorder, the fear of having a panic attack during sex, or the thought that sex can cause a panic attack, leads to arousal and interference. Becomes a terrifying experience and a terrifying thought that if I have sex, either I'm going to have a panic attack or it's going to cause me to have a panic attack. And nobody wants panic attacks. In social anxiety disorder, the sexual performance anxiety is prominent, as well as generalized fear of negative appraisal. And in generalized anxiety disorder, the vulnerability to what-if thinking and catastrophic thinking leads to more anxiety. What-if thinking, what if? With OCD, intrusive thoughts, sexual obsessions, perfectionism, guilt, shame, contamination obsessions, and other compulsive behaviors clearly interfere with the pleasure response. With all of these things going on in their thoughts and in their actions and behaviors, it's unlikely that there's going to be a positive, pleasurable sexual experience. And with PTSD, the flashbacks that can occur during sex and the fear of loss of control and the mistrust issues prevail and again interfere with the sexual pleasure response. If one goes to one's primary care doctor and mentions a sexual problem, typically here's what's going to happen. There's going to be an evaluation of the medical cause and probably a prescription of medications such as vasodilators, antidepressants, hormone replacement, or devices. And the knee-jerk response of go get some counseling. When people treat sexual dysfunction, here's some of the basic treatment modalities. If it's delayed ejaculation, there's again evaluation of medical causes. You try to help resolve any shame or anger issues that are occurring as a result of this problem. Men are encouraged, and women as well, to avoid masturbation and pornography, because that makes it harder to have orgasm in an interpersonal situation with a real partner. And conjoint therapy is essential. Again, I think another point I'd like to make here at this particular point in time is conjoint therapy should really be a very central therapeutic method when you're dealing with sexual disorders and anxiety disorders, but certainly when they're both. It affects the couple. and it goes back and forth. So if the other person who's involved can be involved in the treatment in terms of understanding, reducing some of the interpersonal conflict, and actually an aid in doing whatever things need to be done exercise-wise in the treatment, it's essential. Erectile disorder, here we have, again, evaluation medically, and here we recommend if there's devices that can be used, mindfulness therapy, mindfulness meditation rather, cognitive and behavioral methods, and again, conjoint therapy. With female orgasmic disorder, behavioral methods like sensate focus and mindfulness are really important, as well as the conjoint therapy. With female sexual interest and arousal disorder, mindfulness is essential, psychotherapy, medications at times, and again, conjoint therapy. And to continue with genitopelvic pain, medications are helpful. Education about chronic pain. For some people, pelvic floor physical therapy is used. Desensitization methods and mindfulness therapy, as well as the conjoint therapy. Male hypoactive sexual disorder is very often treated with hormone replacement, as well as cognitive techniques and helping them resolve whatever avoidance mechanisms there are that are playing a role in this hypoactive sexual disorder. Premature ejaculation, cognitive behavior techniques, mindfulness medications, and definitely conjoint methods. And with medication and substance, there has to be an evaluation, education, cognitive therapy, and conjoint therapy. When there's a mix of sexual disorders with anxiety disorders, for instance, with panic disorder, it's essential to help a person understand panic disorder, correct some misbeliefs that they may have about the connection between panic and sexual dysfunction, introduce methods for panic control, create a gradual exposure to sexual activity, and also the conjoint therapy. With social anxiety, there's got to be a lot of work done on performance anxiety in general, and then an evaluation of whatever negative core beliefs that they have related to sexual behavior, and then the more standard mindfulness and acceptance methods, exposure and conjoint. With generalized anxiety disorder, the focus has to be on the worry mechanism and the reduction of what-if thinking as it applies to sexual response. With OCD, a focus on obsessions related to the sexual behavior and developing techniques to reduce intrusive thoughts is essential. And to help identify and reduce compulsive behaviors that negatively affect sex and exposure and response prevention. And with PTSD, education about the effects of trauma on the sexual behavior and avoidance of intimacy, and techniques to reduce negative hyperarousal that interfere with the pleasure response. And also EMDR has been associated with being very helpful. I'd like to discuss with you a few examples of patients that I've seen over the years to give it some more life. An example of generalized anxiety disorder patient is Sam. Sam had a significant level of stress and worry related to stress that he had with his business and COVID. This led to somatic symptoms that impacted on his general health. He developed a low interest in sex and fearful avoidance. This limited all his physical activity as well as his sexual activity. Treatment involved helping him with his GAD, and some cognitive behavioral techniques were used, but he still experienced sexual avoidance, and then even when he wasn't avoiding, he had difficulties maintaining erections. Conjoint therapy was used for that. At times he was on an SSRI for the intense worry mechanism that he had, but gradually, as his GAD improved, he was able to then entertain the idea of getting back to the sexual life with his wife, and we worked on specific methods that related to that, and he was able to achieve a nice sexual life again. Justin, he's a young man with panic disorder. He was a law student who had lots of stress in his first year of law school. He started having panic attacks as a result, and he had cardiac symptoms that scared him so much he went to a cardiologist and had a very comprehensive workup, which was negative. But they put him on an SSRI because of his panic, which then caused his symptoms to become worse. And he had more cardiac symptoms and became obsessive about his heart. So much so that he had to drop out of law school because he was afraid his heart rate would go up when he was studying and taking a test. And in his relationship with his girlfriend, he started avoiding having sex because he was afraid of getting his heart rate up. Eventually, that relationship broke up. And little by little, he avoided all kinds of even walking. He was so afraid of getting his heart rate up. So in his case, we treated his panic disorder, and he learned techniques, and there was a lot of psychoeducation about the connection between panic and normal increase in heart rate. And little by little, with desensitization, he improved his overall handling of anxiety and stress, and eventually get back into law school and got back with his girlfriend. We did some conjoint therapy, and that went well, and I heard from him intermittently that things were going well. Another example is Devin, who has a social anxiety. He's a patient with hyperhidrosis, which is the profuse sweating, and he would avoid situations where he could see people or that people would maybe notice his perspiration. He wouldn't date because of this, and he wouldn't go to classrooms because he would think maybe people were noticing that he was perspiring. We started cognitive behavior therapy for his social anxiety disorder with a lot of work on the belief system, especially related to his hyperhidrosis. And we did gradual exposure situations and social situations. And he started to improve dramatically, cared a lot less about whether he was sweating or not. So that would improve his sweating response. Eventually, he started dating, had initial worry about dating and sexual activity, but more CBT on that. And then some conjoint sessions with his girlfriend helped him cross over the bridge on that. The next patient, I have two more before we kind of, I guess I would wrap up in a few. Michael was a patient with OCD. He had severe contamination issues related to intrusive thoughts that his sperm, could actually survive outside his body and his wife's and somehow impregnate somebody else. He would avoid sex, wash his bed sheets every day after his wife would leave for work, and would be compulsively hand washing all day long. Intermittently, he would have compliance sex because of the conflict that was presenting in his marriage, but eventually he couldn't, and his wife left him. When he sought treatment with me, it was initially for OCD, and then it became obvious that whereas OCD, a lot of it landed, and eventually we were able to get his OCD under about 75% control, some of it with medication, and he was not able to re-involve himself with his wife. She was gone. But it's an example of how an anxiety disorder can impact there. And finally, an interesting one is Joe, who had PTSD. He was a patient who was traumatized when his wife told him details about her sexual experiences with her first boyfriend. Her descriptions were so vivid that he was very traumatized by it, and then continued to have visual images of what he heard about. Subsequently, when having sex with his wife, he would have intrusive thoughts, the thoughts and images of her with her boyfriend. This led to anxiety and disruption of his ability to have a pleasure response, and over time, he began to avoid the sexual interactions with his wife. He came to see me because of this, and we worked on PTSD issues as well as methods to interfere with the attention to his intrusive thoughts and to replace that with more sensate focus experiences. And we also did some conjoint therapy that helped resolve a lot of the issues that had accumulated. So last slide for the future. It's going to be imperative that medical and mental health teaching institutions include education about sexual dysfunction in their programs. Clinicians need to include sexual dysfunction questions in their evaluations, just like any other symptom that we ask about, whether it be sleep or any other issue. Clinicians need to understand and address the biopsychosocial dimensions of patients' symptoms in sexual and anxiety disorders and their interaction. And finally, clinicians need to be able to apply appropriate empirically based treatments to the patient's problems rather than fitting the patient to our treatments that are available or the ones we are familiar with. These are things that need to improve in the future, and I hope that a talk like this today and our group discussion in a little while will stimulate that for the future for all of us and in all the programs that teach us. Thank you for listening, and we'll see you in a few minutes.
Thank you so much, Dr. Rosen. We're going to kind of continue. I'd like to just quickly share my screen so I can welcome my panelists again. Okay, thank you, everyone. Thank you, Dr. Rosen. Thank you to our panelists who have been answering questions throughout. Please feel free to submit them at any time. Again, we will be using a dedicated Q&A session in quite a bit. But I'd like to just start off with introducing our panelists and thanking them for being here today. Dr. Andrew Rosen will continue to join us to discuss further. We also have Ms. Shaman Ajan, who is the CEO and Clinical Director of Shaman Ajan Psychotherapy. She received intensive and rigorous postgraduate training at the Modern Institute for Sex. She is a certified in CBT and an AASECT certified sex therapist, also a board member of the National Social Anxiety Center, as well as a graduate level instructor of CBT courses at Boston University School of Social Work. We have Mr. Larry Cohen here with us, who is co-founder and co-chair of the National Social Anxiety Center. He is certified as a diplomat in cognitive therapy through the Academy of Cognitive Therapy. He founded and directs the Social Anxiety Health Clinic in Washington, D.C., where for the past 33 years, he has served over 1,000 persons with social anxiety and individual CBT, as well as 120-week social anxiety CBT groups. Thank you so much for being here. And last but not least, we have Dr. Deborah Mullen, who is a professor in counseling psychology graduate programs at Texas Women's University, a licensed psychologist, and a certified sexuality educator with the American Association of Sexuality Educators, Counselors, and Therapists. Her research centers on sexuality, reproductive justice, multiculturalism, and training and professional issues. Deborah is an associate editor for Psychology of Women Quarterly and co-chair for the forthcoming APA guidelines for sex-positive practice, sex and reproduction in professional psychology. Everyone, thank you so much for joining us. Just for best practices, so there isn't any kind of overlap, please just like unmute and mute yourself while we're talking, just to make sure that the audio is as clear as it can be. I'd like to just open up this conversation with a question to all my panelists. How do anxiety disorders affect sexual behavior? I know Dr. Rosen went a little bit further into that, but I'd love to have a conversation about it.
Well, I'd like to jump in and just say thank you for having me here. And I'm excited to be here with all of you guys. And Dr. Rosen, you did an amazing job. Thank you for preparing all of that and sharing all that information with us, and also inspiring us and hopefully a new generation of therapists who do sex therapy as well. But I would also, to answer the question, say that if you are experiencing issues with anxiety or confidence even, or shame or body image or any of that, you're most likely going to be experiencing this in every area of your life, and that includes in your sexual life. And when we're talking about anxiety specifically, this can lead to a fear of intimacy. These feelings of being rejected or even judged or criticized often show up as avoidance with our intimate partners or in intimacy in general. And so if you're not connected to your body because you're in your head, and what we know is sex is really all about sensations, right? It's a sensory experience. It's all about what's happening in your body. And you're not really going to be able to connect with what's happening in the moment sexually with you. So that would be my 2 cents initially.
Thank you, Shaman. To follow up from that, one main point I'd like to make is that in the case of sexual performance anxiety, it doesn't just overlap and relate to social anxiety, it is social anxiety. Now, Andy, Dr. Rosen made a point that there are other anxiety disorders that may cause sexual dysfunction and other sexual problems. But in the case of sexual performance anxiety, which is basically the fear that we will be displeasing to our sexual partner, that is the same as the fear of we will be not this exactly the same. That is in the same realm as the fear of we will be displeasing to our conversational partner, or the fear that we will be displeasing to our boss or coworkers, or to the audience if we're a stage performer. And indeed, people with sexual performance anxiety or sexual social anxiety, I often call it, because I'd rather not have them think of it as a performance, but that's the problem cognitively. They tend to think of their engaging in sexual activity as a performance, much like a stage actor, albeit with an audience of typically one, but still an audience who is reviewing them. And so many of the cognitive and behavioral strategies used in treating social anxiety disorder are really important in treating sexual performance anxiety as a result.
So I'll jump in too, and I want to echo what a privilege it is to have been invited to serve on this panel. And thank you so much, Dr. Rosen, for all that you enlightened us with. I really enjoyed your presentation. I'll chime in and maybe ask for a little audience participation. I know that we don't see you, and that's okay. I know some of you have made use of the reaction button at the bottom of the screen. So whether you do it in the chat or the reaction button, you can use the heart button for reaction for this question or put it in the chat. How many of you who are present feel like you were given all of the tools and education you needed for a healthy sexual life? So let's see how many of us here would answer that positively. Okay, there's a thumbs up. And various other reactions. Okay, those are great. I appreciate that. So I asked you to do that because whether or not somebody meets the full-blown diagnostic criteria for an anxiety disorder, as you can see from just our wildly unscientific poll, few people here, and we're a room full of professionals, so arguably we would think we might be in a special camp, have the necessary tools to be able to have fulfilling, informed, freely chosen sexual lives. So I would say that that's how I see anxiety as running in tandem with sex, is that we primarily, many of us are raised in sex negative cultures. We are denied access to information. We are fed myths about sexuality. And it's really difficult to cultivate a healthy sexuality with that in mind. And anxiety just seems like a natural consequence when we don't properly educate and inform people. And that includes our clients, but as you can see, it includes us too. And sometimes we're clients as well.
I'd love to just kind of follow up on that. We're talking about, we aren't necessarily getting the best education even as professionals. So what other challenges do clinicians face when they're trying to provide treatment, dealing with sexual issues, dealing with anxiety, and how can they effectively address these issues?
Well, let me address that again. I mean, what I tried to communicate before was that, that concept of it's the elephant in the room that we know is there some of the time, but most of the time we forget about it. And, we kind of are trained to just jump in on whatever the patient is presenting in that first appointment or two. Like, I can't sleep, or I'm scared about this, or yeah. So, when a patient comes in, they give us a lot to work with. And, you don't want to say, well, let's put that on the shelf and I want to ask you about sex, because if we did, that would be a problem. So it's like this elephant's there, we know about it, but we kind of forget about it, or we get distracted from it. And that, plus our lack of, awareness of the issue, and cultural things, and prohibitions, and all kinds of other reasons, including lack of training. We just don't get to it unless the patient is really loud about it. And then we assume all the other symptoms got better. Okay, we're done. You can go back to your life, and I think you'll have a good sex life. But I forgot to ask you.
I would say, just to echo what Deborah was saying, I think one of our biggest challenges is the sex negative environment that many of us were raised in. And I'm not just talking about in the home, I'm talking about in our schools, I'm talking about in society at large. And so really being able to overcome that stigma that exists around just talking about sex on a very basic level is a challenge. And this impacts everyone, not just, our clients. It impacts our parents, right? And their ability to talk to kids. It impacts general practitioners, family doctors, OBGYNs, and yes, us therapists as well. And so we have to overcome our own stigma that exists within us around this being normal, or not really having the training. We need to get out there and kind of seek the training and get comfortable with our own problems around sexuality, with our own, stigmas that exist for us personally, so that we can get more comfortable and we can be more competent. And be able to help our clients be able to talk about these things that are so important, this part of their life that's such an important part of the human experience.
The truth is, tweeting has replaced sex.
Now called Xing or whatever. I've learned over the years to make it a routine question in my assessment sessions with clients. And I learned that because, as you all were discussing, I used to think a client would just bring it up if it was a problem for them, and then I would be happy to talk to them about it. And indeed, some people do, but actually my experience has been that most people don't. But when I routinely ask them, then I find out. And actually, I find out different interesting things that are useful, even if it's not a problem for them. So for example, I think your slides, Andy, said that maybe 30% of people with social anxiety disorder have some form of male sexual performance anxiety, something like that, which means 70% don't. But even for those who do, which is roughly, what I experience in my practice, but even for those that don't, it's an educational tool, because I ask them, why not? And usually it's because they're just engrossed in the pleasure of it all, which is great. And that's what we want to help them do when they're in a conversation, to be engrossed in the pleasure of the conversation. But of course, for many other people, no, they're very self-conscious about how am I being perceived? How am I so-called performing? How long will my erection last? And will my sexual behavior be satisfying? And things like that. So I've routinely asked these questions, and I preface it, and this may be completely unnecessary, but I do it. I preface it by asking, stating that, so I have a couple really personal questions to ask you. And this is after I've already asked them plenty of personal questions, but I'm sort of setting them up for even more personal questions. So let me know if you're uncomfortable to talk about that. And actually, I don't know that I've ever met anyone who told me not to when I started asking them about the sexual questions, like, do you have any anxiety problems when you're being sexual, any functional problems when you're being sexual? I don't know that I've ever had anyone turn off that conversation. But by prefacing it, I think what I'm doing is acknowledging that it may be uncomfortable for them. And honestly, the other thing I'm doing is that it gives me a moment to get comfortable with it too, which is useful.
I think that's great, Larry. And I think that, you're also giving them control in that moment to decide whether or not they want to discuss it or not. I do something similar, but at the beginning, before I even get into the biopsychosocial and the information taking, I let them know that sex is on the table here, race is on the table here. If politics are affecting you, it's on the table here. We can talk about anything and everything and anything in this room, and you have the right to decide if you're comfortable with talking about something or not. And then when we move into the gathering of information, I just ask like it's routine, because it is routine, and then they get to decide whether they want to talk about it or not. And like you, I've rarely had any experience where someone has said they do not want to talk about it. There have been times. I work with trauma survivors, so sometimes they are uncomfortable discussing it initially. But in most cases, it opens them up to be able to talk about some of these more difficult areas.
Yeah, I love all these wonderful ideas. I think, yeah, having it as part of a regular intake just makes good sense when as we've talked about, that sexuality affects most people's lives in some way. And it's certainly, if somebody's coming in with symptoms of anxiety, depression, eating disorders, body dysmorphia, it's hard to imagine that sex wouldn't also be impacted. So I think just in the way we regularly assess for somebody's social support or somebody's faith identity, et cetera, that we learn how to ask questions to get folks to talk. I've also seen a clinician who says, I wanted to ask you if you have any questions or concerns about sexuality. And if clients in an initial session say, no, I don't, then the therapist can say, I just want you to know that as those arise for you, or if they arise, that I'm comfortable addressing sexuality in here, and welcome your questions and concerns. Sometimes I've also seen signs. You can just get one online, get an image that says sex positivity is spoken here, and hang it in your office, or put it virtually, or put it on your website, ways that people know that you're approachable and open to having those discussions. And if you're sitting in the audience thinking, well, I'm not comfortable with that, I appreciate that as well, because again, we don't set people up, clinicians or anyone else for that matter, to be comfortable talking about sex, in which case I go back to the training issue and say that if you're feeling inspired by this conversation, that you start to demand, as I have, that sexuality be a required part of any mental health training. I think there's ways we can do that with our state boards, with the organizations we serve, with our universities, and we really need to do that. And if there's enough people that say this training should be mandatory, I think we'll see some traction.
Those were some great tools, and I think a sign, even if it's a quiet way to emphasize that, is always important. Are there any ethical considerations that we need to take when we are venturing into discussing sexual health or sexual dysfunction with clients? And does age come into play?
Well, age is an issue, and it's an interesting one because of my training and my experience and my focus on treating anxiety disorders. I can't begin to tell you how many times I've seen 16, 17-year-old, 18-year-old boys who are anxious because of their sexual performance, problems with erection. And that's, surprising. Most people don't think of that age group as having issues with it. But it's really, I don't have any actual numbers on it, but I've been surprised to see the number of kids who have the problem. So, I don't know if it interfaces with ethical issues or not. I think, the obvious issues when it comes to sex are clear in the clinical, environment, but I think the more we look for it, the more we're going to say it. The more we talk about it, the more cases we're going to identify.
I don't work with children, or adolescents, so I'm not quite sure about the protocol there. I do have a 15-year-old daughter, so I do know when we go to her annual appointments, they ask me to leave the room so that the doctor can talk to her about if she's sexually active, if she's using any kind of drugs or drinking, and all of the other stuff that she might not feel comfortable talking about with me in the room. And I happily leave. Bye, see you later. So I would assume there's something similar in place. I just don't have that information for you.
We had an attendee say ethical means getting real training to be able to treat or referring out, which I think is something to take into mind, building that network of professionals that you can rely on, like people who are here today.
Yeah, and I also like to add that, I think it's important for us to let our clients know, like we've discussed a little bit earlier, that they're in control here, that we're not going to force them to talk about anything, that they're the ones who get to drive the way this session is going and get to say no. They have permission to say no when they want to, so that they never feel forced, that they're always feeling comfortable and like they're in a safe space to be able to talk about what they feel comfortable talking about.
That's so important. I want to highlight after the initial assessment questions, when you start working on sexual anxiety problems, it does involve asking rather detailed questions, just like you would with other forms of social anxiety, about what are your thoughts, what are your safety-seeking behaviors, things like that, which, in non-sexual settings, people with social anxiety are generally quite free to share. But in the case of sexual settings, the answers to those questions are really quite intimate, that they may not have spoken about to anybody, literally anybody in their life. And so even though I've already said in the very first session, if this is uncomfortable for you to talk about, let me know and we'll move on, or talk about it when you're ready if you want to in the future, I'll repeat that when we start getting into more detailed questions so that they feel in control. And I've had clients who are actually very open to talking about sexual problems, but up to a certain level of detail. And when it got a little bit more detailed, they said, I'm not comfortable at this point. And you just accept that and move on, which doesn't necessarily mean change the subject. It just may mean back down in terms of the level of detail. And it's fine, but you keep the control in their hands.
It's an interesting phenomenon that we're talking about the details and how much to ask when it comes to sexuality. But there's another one that we probably have all experienced with patients, has nothing to do with sex. Have you ever asked a patient, how much money do you have? Or how much money do you make?
When they want a discount, I do.
If you ask the response, if you ask the question, which I think, none of us really do, but if you ask like a specific question like that, it will generate, I think, in them and us, like, why is he asking? What does he want? Why does he want to know that? Why is that so important, those details? What's his motive? And so there's two areas. It's sex and money. Again, it comes back down to that. We're very, very private about. But sex.
Yeah, I would add death as well, that a lot of people are phobic about talking about death. And I think some of what I'm thinking about is just how important it is to ensure that people who come see us for therapy that we give them some education and guidance about what therapy is and what it isn't. And therapy is exactly a place to be able to talk about the kinds of things that might be considered impolite or taboo, and that to let clients know that we're open and comfortable talking about a range of issues that, again, might not be acceptable in some places. And I'll share that the research is really clear that when clients are asked most of them do want to talk about sex. And they often report that they don't because they're taking their cues from their therapist. So we could talk a lot, and we have, and it's important to talk about what might inhibit clients from discussing sex or raising the issue. But I think sometimes the issue is with us as clinicians, that we might not be comfortable for all the reasons we've been talking about. And so part of what I think could help catapult our work considerably is just having these conversations and attending trainings. And there's so much online now that you can get, and there's great books we can recommend, so that you can have the training to be comfortable to be able to address sex with your clients, so that you're not the reason that sex isn't being talked about.
That's such a great point that you made, Deborah. And just to piggyback on that a little bit, I like to let my clients know, like you said, what therapy or sex therapy is and isn't, and what our boundaries are, by adding that you don't need to show me anything. I don't need to witness anything. I don't need to see your genitals. We won't be doing that in here. I won't be demonstrating anything with you. I won't be touching you. So they have a clear understanding of what we'll be doing. It is talk therapy. And I think that's an important piece of it, knowing what our boundaries are and sharing that with our clients as well.
Yeah, that's such a good point. One other thing I just wanted to share in case people aren't familiar with it, is the PLICIT model. So I put the acronym in the chat, because I think what I'm seeing both in some of the questions being posed and some of the comments is this idea that people need to have a specialization to be able to address sex in therapy. And this model has been around since 1974, so it's stood the test of time. I think it's pretty helpful. But the idea is the P stands for permission. So oftentimes when clients have concerns about sexuality, it's because of the sex negativity they've been raised with. And they need to know that sex can be positive and healthy, that is associated with so many positive outcomes, like Dr. Rosen presented in his presentation. And so that clients sometimes just need permission that it's okay to be sexual, it's okay to masturbate, not even just okay, that there's a lot of tangible benefits for that. Earlier when you were talking, Dr. Rosen, about rates of orgasm for women, I was thinking about the research that shows that lesbian and bisexual women have more orgasms with female partners than they do with, than bisexual women do with male partners, and that most women can orgasm when they're by themselves, which should raise all kinds of questions about what happens in encounters where women aren't experiencing pleasure as much. LI in the acronym stands for limited information, is oftentimes the things that clients bring to us can be addressed by just giving some factual information, some content, and then specific suggestions, and then intensive therapy is the last letters. And that's only for those kinds of treatment issues that come up that are beyond our capacity. But many times there are ways that we can just correct misinformation, abolish myths in the therapy room, give permission to people to explore sexuality in healthy ways, all sorts of things that you don't necessarily need specific training for, just a little bit of additional training if you haven't had it in your coursework to this point. I think you'll feel relatively more comfortable being able to have these discussions.
I wanted to respond on a different track to the original question about challenges that we face in working with people on sexual issues. A separate challenge is being willing to work with an individual when conjoint therapy isn't possible. I fully agree that whenever possible, couples therapy is ideal in working on sexual problems, at least sometimes just as an adjunct, but sometimes as the main focus. But it frequently isn't possible. It may just be because I work with lots of socially anxious clients, and overwhelmingly they're single, not always, but they do typically be single because of their social anxiety disorder. And so they don't have an ongoing partner, or they're just lightly dating and they don't feel ready to bring that person they've been out with 2 times into a session, of course, as most people I imagine wouldn't be. So there are various strategies that we can use. It's similar to when you're working with somebody on phobias, and the phobic trigger is not always available, like an airplane ride, which may be too expensive, or whatever their phobia may be, that often what we'll do initially, or the same with OCD as well, is do imaginal exposure. And there are ways of doing that sexually as well. It has to do with sexual imagery, often while they're masturbating. So as homework, obviously. But there's strategies that can be used when working with single clients or maybe coupled clients, but where they can't bring in the partner.
Thank you. I'd love to discuss a little bit further about how we as professionals can continue reducing the stigma of discussing sex in therapy and healthcare kind of broadly. Would you be able to touch on that?
Well, I mean, some of the basic things, just like what we're doing today, is big. Maybe today we have 90, maybe next time we have 9,000. You know, so and certainly in any of our work, if we do any research or writing or books or guides that we create outside of our own clinical work, that's another way to let the world know, the world of clinical practice know that this is so important. You know, I think it's helpful to kind of convey a kind of a surprise that we have this issue. I mean, if you think about it, it's shocking in a way that such a centrally important dynamic of life, you know, we never get around to really working on. I mean, we're talking about it today, but still, I mean, I look back when I was writing my little history of myself, and I'm like, where was I? I did a chapter in a book on anxiety in couples. Now, granted, it was in the early 90s, but it was like, why didn't I think of mentioning that? So I just think, you know, it's kind of like a lot of things. Once we start talking about it, it will start to germinate and become more and more. And it could take years, but I think, you know, whatever we can do. And then certainly working with patients helps. Although patients may work on it and feel very happy that we help them, but they're probably not going to go tell the world about it. So it sort of still remains pretty close to the vest. But I think what we're doing today is a big deal on that.
I think also if we're working with an interdisciplinary team, or if our clients, you know, got referred to us by their doctor or a psychiatrist, or you know, somebody else kind of within the realm of healthcare, we can talk to them a little bit about what we do and the importance of exploring, you know, a sexual history and understanding the link between life struggles and struggles sexually as well. And, you know, whenever I get a chance, I tell people that I don't have a sex therapy practice, but we all practice sex therapy because sex is a part of the human experience. And if someone is coming to us with depression, then they probably have a lack of libido, or it's affecting them sexually. If they're coming to us because they have anxiety, then, you know, they might have performance issues, they might have arousal issues, they might be hyper aroused. If they're dealing with stress even in their lives, they might lean in to sex as a way to manage the stress, or in a lot of cases, women in particular tend to push sex away. They have difficulty getting aroused when there's too much sex, or they're handling too much stress, or they're handling too much of the mental load. So just understanding and having these conversations about how life struggles impact us sexually, I think is helpful as well.
Thank you. I think that makes sense. And you discussed a little bit about treatment overall. How could we most effectively incorporate conversations and sex in our regular treatment plans? And how might one of our professionals joining us today, start by making a small change in a patient they have right now.
Well, I think, we've talked about it a few minutes ago, introducing it in our initial assessment. We look at all kinds of things. I ask questions all the time about anxiety symptoms and then how it's affecting functioning, whether it's sleep or appetite or just, overall experience of life. And that has to go into that assessment. There's all those neurovegetative signs that we look at, that has to go in there. It's like an automatic. It's just no more not asking about it. And if you get a kind of a confusing response or a hesitant response from a person that's different from when they tell you about their sleep, then I would say, well, let's talk about that. Let's look at that more than maybe the other things that they just, kind of checked off. So I just think it's from day one, we just include it as a normal part of what we do.
Yeah, and I would piggyback on what Dr. Rosen said to say, if you've been working with somebody and this is a new idea that you haven't had it as part of your intake process, it's not too late. So if you're working with someone who's presenting with anxiety symptoms, and you've been working with them for a while, you could say, I've been thinking about the way that we've talked about how your anxiety affects your sleep or your appetite, et cetera. I wondered about how it might affect your relationships. And I think sometimes starting with relationships for anybody who wants to test the waters, maybe this feels like too big of a leap to say, how does it affect your sex? But starting with relationships, how does it impact your relationships with people, with your support circle, and then maybe narrowing it to intimate partners? I think that could be a way to bring up the topic that might feel a little bit safer than just coming into a succession and saying, so we're going to talk about sex today. So there's lots of ways I think that we can gently introduce the topic. And again, I would want to reiterate that the research shows that it's not usually that clients don't want to talk about sex, although I appreciate the distinctions between the level of detail that some clients may be comfortable with. We might also think about the identities that we are coming to the room with. So we might think about whether somebody would be comfortable if we're a different gender than they are. That can be difficult or maybe pose particular challenges. We can talk about, ideas about race and sex and the intersection of those and myths that we've been taught about that, about race and sex and how that might enter into the room. So all those things, but I think we can still have these discussions. And I think clients really want to have those discussions.
Or we could show those 30 pictures from What About Bob?
I think it can also be helpful to give clients a bit of a rationale. So, having them understand why we are asking these questions. And there's so many reasons, but one I like to highlight is we want you to be your own, detective, your own monitor here also. And so as you learn more about your anxiety, you'll be able to catch it and then intervene a little bit earlier. And this is another way that you might be able to catch that you're feeling a little anxious or your anxiety is ramping up. You're not as sexually active. You're not as you're not as interested in sex. You're pushing sex away. You're not experiencing desire or arousal. What's going on here? That's another way for them to become aware that something might be going on with them.
I think that's a really good point. And while we're talking, I'm also thinking about widespread cultural issues happening, prescriptions against sex. So I would be surprised if folks who are here today aren't seeing the effects of this in their practice. So for example, we're just a little bit more than a year out from the Dobbs decision. So people who want to access abortion in many places, including where I am in Texas, can't do that. We don't often think about abortion as a sex-related issue, but it most certainly is. We could also think about, I have a number of students right now who are doing dissertations with me, and they're looking at issues affecting trans and gender diverse people. Gender and sex go hand in hand as well. So thinking about the anxiety that people feel when there is widespread legislation to either take away rights or codify not having rights that are basic to people who are not part of marginalized groups. So I think those would be other ways, maybe entry into being able to introduce topics around sexuality, because we're seeing them played out, at least in the US, on a national basis.
Thank you so much for bringing that up. I think that's a really important part of the conversation. I am going to turn to our audience questions, and I'm going to do my best to organize them because we've gotten so many and we're so appreciative. And hopefully we can get to as many as possible. I think a natural transition is we were just talking about sex and gender and cultural identity. I was hoping we could talk a little bit more about how the treatment options might vary in those, but also kind of bring in age diversity into the conversation, where older populations or geriatric populations might come into play.
Well, I'd like to say, you know, people, the saying, just because there's snow on the roof doesn't mean there's not a fire in the furnace. If you go to a lot of these nursing homes or residential, you know, areas, you'll find they are very sexual. They're having a lot of sex. They are sexual. They're talking about it. They're doing it. And because there might be some health stuff involved there, you want to be able to have these conversations with your clients. If there's dementia there, they might not be aware or remember certain things are happening. If, you know, are they using protection? Are they being safe? These are conversations that we need to have, because just because we're getting older does not mean that we still don't have those urges and that desire. So yes, let's extend these conversations to, you know, our
We're
older
here in
versions of
Florida.
ourselves.
In South Florida, there's a few older people, and you know, starting new lives either because of loss or even, I mean, there's a lot that you read about in the media and the literature now about gray divorce. There's a lot of divorce going on, much more in the gray area in the 60s than in the 20s and 30s. The 20s and 30s can't afford it, and the 60s can afford it. So there's a lot of people out there that are engaged in meeting new people, and they want to have sex, but, and there's a big but in there. And what some of these people are, for instance, on medications that interfere with the sexual response, certainly on the part of men who can't get erections because they're on, you know, medications for blood pressure and other things, and women as well are on medications, or their, you know, hormone issues are causing them to not have drive or desire. So all these people are all of a sudden finding they're looking for partners, and, you know, if they're lucky enough to find a partner, two people who can partner, then, you know, they want to really partner. And then there's all kinds of issues that get in the way, which certainly in the older population, they've given up, they've lost a lot. They've lost careers. They're not working. They're not getting, you know, a lot of interesting activity all day. So they've given up a lot. And now they get excited about the possibility of a sexual life, and then they can't get it. So yeah, there's a lot of interaction between the patients that come in, and they actually do verbalize a lot about their sexual issues and disappointments or anxiety about not being able to perform. You know, just met so-and-so and she loves me, but I can't perform. So yeah, there's definitely the age issue for sure. And South Florida, you see it.
A small but I think important detail that may be obvious to some, but was a surprise when I learned it quite a number of years ago, is that the simple word sex means very different things to different people. And so I used to, when I would ask questions about sex, simply use the word sex, because that's what I always learned. And it was, at least as a gay man, that word was rather all-encompassing. But to a lot of people, some of which has to do with sexual orientation, some of which has to do with generations, but to a lot of people, sex, the word sex simply means sexual intercourse, and sometimes even only specific forms of sexual intercourse. And so when I'm asking broader questions about sexual activity, I usually use broader words like sexual activity or sexual intimacy or sex and other physical intimacy to try to make sure the client understands that I'm talking broadly speaking and not whatever narrow view they have of the word sex.
That's a great point. I'm glad you brought that up, Larry. What I was going to say was just stepping back from the issue of sex and older people specifically, thinking more about what messages we get, and by extension our clients get, about who sex is for, and who do we get seen in media and popular culture who are entitled to sex, and about how when we get further and further away from our fertility windows, it becomes more and more taboo. So just as many people are uncomfortable thinking about older people having sex, grandparents and parents, people are also uncomfortable thinking about children as sexual beings, even though people are capable of sexual response and sexual pleasure from birth until the end of life in most cases. So I would probably impress that into the conversation about the importance of looking at why do we have these taboos in the first place. And some of it is because many people are raised with the idea that sex is for procreation, or somehow that's a loftier use of sex than other things. So we really need to dismantle the whole idea about why people have sex in the first place, and the fact that actually very little sex is for the purpose of procreation. It often results in procreation, but intentionally very little sex actually is for the purpose of reproducing. So thinking about that, and again, I think some of that permission given to older clients in terms of, this is a good, healthy part of life, and people can and are sexual until their 80s and 90s, and it doesn't mean that there aren't accommodations that need to be made, but just that's an okay part of life to explore, and thinking about the ways that we are given messages about, quote unquote, a dirty old man, or the idea of parents and grandparents as sexual makes a lot of children and grandchildren really uncomfortable, and we need to ask ourselves why. And I think that will go a distance in helping to to take down this idea that older people shouldn't be sexual, or that somehow it's gross.
Or even the other way around, right? Where, older people or parents or aunties or uncles, whoever, are labeling, little girls as fast, or, because, or sexualizing young bodies or young children because they develop earlier. At my practice, we run a group for female adult survivors of childhood sexual abuse that we've been doing for many, many years. And recently we have created a new group for Black female adult survivors of childhood sexual abuse, because there is that additional layer of race there, and being sexualized at a very early age, and being the adultification of young Black children as well, and the anxiety that creates in these young Black women, who then become Black women who are having difficulties around being sexual or having sexual relationships. So just wanted to add that little piece there.
Yeah, that's a really good point. I'm so glad that you offer those groups at your practice. So important.
Thank you so much. We had someone who wanted all of our panelists to continue addressing the impact of anxious overthinking on sexual issues, and how someone might provide recommendations on how to manage that.
Well, the biggest issue, with overthinking is that while you're thinking, you're not sensing. And, I talk about sensing with all my anxiety patients, because I go back a little history with it. When all of us way, way, way back when were sitting outside our cave after dinner, we didn't think very much, and we didn't talk very much. We didn't know anything. So the part of our brain that was really used was the sensing part of our brain. We'd smell, we'd look, we'd listen, we'd taste, and we would touch, but we didn't think. We didn't know anything to think. If you fast forward, now all we do is think. We don't know how to sense. which is why we talk about mindfulness so much, and why people are turning to all of that, the apps for like Calm, because our people today don't know how to sense. All we do is think. And sensing is almost an interference with our ability to think and multitask and analyze and plan. And I have to do this thing tomorrow. And so the biggest issue I think with helping people, whatever their anxiety disorder is, in terms of their sexual experience, is getting them to learn how to, disassociate from the thinking and turn to their sensing. And, way back, I don't know how many years ago it is now, Helen Singer Kaplan talked about sensate focus. That means focus on sensations. That was an initial sex therapy technique. More so today, all we do is think. So, if you're in a sexual experience with somebody, there's two people there. There's you sensing and there's you thinking. How am I doing? Well, what's that noise? And how much time do we have? And what if I'm no good? And what if this, what if there? So you can't really sense when you're overthinking. And so I think if there's one major central, methodology that I talk about with patients, is getting away from the thinking, intrusive thoughts. And that's what generates most of our anxiety anyway, not real life, not real situations. It's our heads. All we do is think. So we have to get people to not think so much.
I fully concur. And that's true with social anxiety generally. People tend to be very much, the common expression is in their heads, meaning focused on their thoughts and their concerns about whether it's a conversation or a performance or some other activity. But that's also true of sexual social anxiety, so-called sexual performance anxiety. And so the old strategy of sensate focus is now called mindfulness. Too many people think mindfulness means meditation. Meditation is internal mindfulness, which is useful for many things, but it's external mindfulness that's most useful for things like social anxiety, research shows, and that includes with sexual anxiety. And external mindfulness means focusing on any and all of the sensations, as opposed to in the meantime, so-called diffusing, meaning treating like background noise whatever thoughts they're having. So just getting engrossed and, engulfed in the tactile or the visual or whatever the other sensations are that they find pleasurable. And so the sensate focus strategies that were fostered decades ago are still important, because they're all forms of external mindfulness to help people get away from focusing on their thoughts and onto the experience.
I agree. I think mindfulness is one of the first things that I go to also with my clients. But I would also say the overarching umbrella that I tend to approach this with is playfulness, because sex is supposed to be fun. And when it starts to feel like a job, when it starts to feel like something that you're worried about, when it starts to feel stressful, it's not fun anymore. And that often occurs when you're stuck in your thinking mind. So working with the client to find new ways to become more playful, to find more joy, to, yes, get in touch with those senses, the sensory experience also, but to be more flexible in the way that they're approaching sex or intimacy and making it fun again, bringing the fun back. And I always find when they're able to make that shift, then there's real progress that starts to happen there.
Yeah, like all these good ideas. I think related to mindfulness is having a yoga practice. So things that help us to experience our bodies as joyful places rather than as objects, which is, I think, particularly a problem for people who are women and non-binary folks as well. So having some kind of physical practice, it doesn't have to necessarily be yoga, but I think because there's so much internalized mindfulness with yoga. I think it's a natural friend to aid in anxiety, but some ways to encourage people to experience their bodies as positive, because there's so few spaces where our bodies can be enjoyed as positive, especially again if we're identified with marginalized groups, because we get so many messages that our bodies are not acceptable as they are. And I would also say, I think just even the way we talk about some of the issues, I know that we've had references to the DSM and to diagnosing people, but talking about sex as a performance, and that so many people see it that way. We talk about like achieving orgasm as though it's an accomplishment. I think even the language we use can be better updated so that we're talking more about experiencing pleasure, experiencing our bodies, or engaging in sex or having fun with our bodies. Has such a different connotation than talking about sex as a performance. I think if I thought of sex as a performance, it would be difficult to approach it in a joyful way.
While you're having these conversations and treating your patients, and they start discussing their sexual dysfunction, do you pivot in treatment? Do you treat that separately and maybe have a different treatment plan for those issues versus the anxiety, depression, the OCD?
Well, I think in general, if a person has an anxiety disorder, my first order of business is to see how much dealing with that anxiety disorder can have a positive impact indirectly, I suppose, on their sexual experience. And I think, probably a large percentage of people will find that their sexual experience improves as their anxiety disorder symptoms, whatever they are, improve. But at the same time, things start to reside in certain places. So if you have an anxiety disorder, it may not affect certain parts of daily life, but it may go into certain other parts of daily life, like your sexual experience. So it may be that lots of people get better when you treat their anxiety disorder, but you probably still have some work to do on the sexual experience with these patients. And so I most likely will make that a secondary destination, unless that's the only place this anxiety disorder seems to be, residing, and they're not having any other symptoms except there. Then of course, it's kind of like, where do the white blood cells go? They go right to the wound. So that's where the wound is, that's where we go. But if there are other places that are bleeding first, you have to tend to those first, I think.
I would agree, and I would say that we would continue to check in on how they are engaging sexually and what their intimate life looks like, unless of course that's what they're primarily suffering with at the time. In that case, we would handle that forward facing. But I also find that dealing with whatever it is they're coming with, and also looking at how it's affecting them sexually, it helps them to be able to say, oh, okay, so it's normal that my anxiety might impact my desire, or oh my gosh, it's normal that my anxiety is making me super worried about getting stress relief through sex, which then has me worried about when I'm going to get it in a scarcity model, and it has me continuing to kind of focus on this sexual piece. It helps to put things into context for clients, and it helps them to also be able to monitor what's going on with them and then attend to it.
It normalizes it. You may say to a patient who's having anxiety, of course it affects your appetite, or of course it's affecting your sleep. Well, of course it's affecting your sexual experience. So it's normal. Let's fix your anxiety.
I think that whenever there is a connection between what on the surface may look like separate problems that a client is having, it's useful and often really therapeutic, but at least useful, helpful to draw the connection, to help a client see, well, gee, your anxiety about being sexual seems to be based on the same sort of concerns you have in your anxiety about speaking up at a staff meeting. They may look like completely different things, and certainly the settings are completely different. But if it's true, I mean, I wouldn't draw the connection if the connection isn't there, obviously, but frankly, it usually is. Then I would help them see, like, your underlying concern in both in bed and in the boardroom are actually the same, that you will displease the audience. And as a coping strategy, a so-called safety behavior, you're very much in your head focused on your anxiety symptoms and focused on your performance, but that only makes you distracted and so-called perform less well. And so it helps clients see the connection, partly so that as they make progress in one area, they can generalize that progress to another area. But also so a client doesn't feel so overwhelmed. They don't say like, oh God, I have 8 problems. Maybe I have one problem that shows up in 8 different ways.
That makes sense. Thank you, everyone. We did have a question that came in and says it often seems that the default for addressing sexual dysfunction is referring your patient out to a sex therapist. That there seems to be a supply and demand problem given the needs of the patient community, and how might we address that?
Well, I would say, I think I answered this question, but I would say that I became a sex therapist, not because that was my primary interest coming out of graduate school, but because, like I mentioned, I work with a lot of female adult survivors of childhood sexual abuse, and formed a group and began working with them around all aspects of that, including reclaiming their sexuality. And I didn't feel competent because I wasn't trained. I didn't feel comfortable because I hadn't done that work. And I went out and I got the training. I spent years getting training so that I could support these women. And I would say I was doing some sex therapy prior to it, but a lot of the work had to do with working on myself, understanding my levels of comfort, understanding where my biases lied, and then, of course, getting the training. I don't think you have to be an AASECT certified sex therapist to do some sex therapy with your clients. Now, I think it's important to know what your limitations are. And if you feel like you're only able to get to a certain point with your client, then yes, that's where we refer out. But we don't hear the word sex and then say, oh, no, I don't do that, because you're doing a disservice to your clients. And personally, I think you're doing a disservice to yourself because you're not able to treat the whole person.
I think I agree with you 100%. And I think ideally, as clinicians, we would all think the same way, meaning, if I don't really feel I know that well enough to be able to help people with that problem, or this particular person with that problem, either I will get some more training in that area. I don't have to be necessarily fully certified, but I better learn a lot more about it, or not. And, I kind of talk about this tongue in cheek all the time. If you go on websites or wherever and you see, or formerly, I guess, the Yellow Pages, and you look up, you see Dr. So-and-so specializing in, and then there's a list of 100 different disorders, No, you can't specialize in 100 different disorders, Find a niche for yourself, maybe a few that you really, really, really know very well, and keep developing that. And that's one of the things that I loved about when I first went to my first ADAA meeting. These are people who really had a real interest in working with anxiety. So I agree with you. I think we just have to know not even what our limitations are, but what we're good at and what we're not so good at.
Thank you. I do want to be conscious of our time and we'll start taking some final questions. I think we can kind of go for 3 or 4 hours if we really wanted to. And if we all didn't have other things to do. We do have someone who wanted to discuss a little bit further OCD intrusive thoughts about sex and how exposure-based therapy might be in conflict with the abstinence model and sobriety if someone does have sex OCD thoughts.
Sasha, could you kind of repeat that? I'm not sure I'm clear.
Sure. So sorry. I'm happy to do that. There was their larger version of their question that I saw earlier. Thank you. So they have a subset of clients who are in recovery for a porn addiction. And part of their treatment is exposure therapy, but that comes in direct conflict with the abstinence model of their sobriety training. So how might they manage that? Which is perhaps a bit of a specific question, but shows kind of a larger conflict in between the discussions of sex.
I don't know. My first response is, if a person has an addiction issue, let's say with alcohol, but they also have social anxiety, our job is to help them become more social and abstain from the alcohol. So I think it's possible to help people engage in their sexual lives and not feel that we're going to destroy their recovery from porn addiction. That's how I would think.
Yeah, I'll go ahead. I'm sorry, Deborah.
No, you go ahead. I can wait.
No, I was just going to say, I think, helping your client, like Dr. Rosen was saying, around the sexual piece doesn't necessarily mean that you're going to involve pornography in that. And so being very clear about, what the interventions are, what the exposures are, and then, helping them with those impulses, maybe that might be triggered by some of the work around engaging in the sexual piece.
Yeah,
But yes,
I was just going to say what I see Carl has put in the chat. I earlier in some of the questions that were submitted, I offered a few links about the controversy of sex addiction and porn addiction. I put them intentionally in quotes. I went to a training once. It was very good. And the presenter started and said, the definition of somebody with a sex addiction is somebody who has more sex than their therapist, which was tongue in cheek, but I still think made a really valuable point. It is not that people can't and don't, have sex or use porn in ways that can be problematic. I just would want to caution the audience as we start to wind down our time together that people often go to that very quickly. So you might see a client that says, I'm a porn addict. I look at porn, 3 times a week and masturbate. So we would do well to question about where they got those ideas about using porn 3 times a week is somehow problematic if it's not otherwise interfering with their lives and their relationships. And again, it's not that those behaviors can't become problematic, but they're so quick. They're kind of I think those terms are sort of overused. And I think they reflect our sex negativity as a culture, that we think that somebody having a lot of sex or somebody having a lot of varied sex or sex with a lot of partners or someone who enjoys porn a lot or masturbates often, that we can be quick to jump to that as problematic or diagnostic. And I would just say to be cautious about that.
Yeah, I think it's more constructive to look at the area of what's sometimes called out of control or at least problematic sexual behaviors. In other words, behaviors that in some way may cause them and sometimes other people a problem, rather than view it as an addiction. And exposure therapy is not used for addictions or for those kind of problematic behaviors. So exposure therapy is used for anxiety and anxiety-related disorders. So I see them as separate issues.
think that's a helpful distinction to make. And I just wanted to start slowly wrapping up to see if we could quickly bring medication side effects into the conversation and how those might play a role.
Well, they play a huge role, whether they be the antidepressants, certainly it can go either way in terms of inhibiting sexual desire or impacting on sexual experience in terms of either premature ejaculation or not being able to ejaculate or inhibited sexual desire on both sexes. So it's big. So it's kind of like a contradiction if depression gets in the way of sexual desire and then you give an antidepressant, you would figure, well, that's going to solve the problem, but it really doesn't. It may make you want to, but it doesn't necessarily help you. So and then you have benzodiazepines also, which also have an impact. Certainly non-psychiatric medications that are used for blood pressure, heart issues, or even hormone issues in terms of hormone replacement. It's the whole gamut of medications do impact.
And not to mention other medications, medications for your heart, medications, blood thinners. There's all kinds of medications that are not necessarily related to mental health disorders that also impact you sexually. And, I would say that if someone is suffering from anxiety or depression and they need their antidepressants, and it's, gotten to the point where it's really interfering with their functioning, then yeah, we're going to go down that road, but it's always important to talk about these side effects with your clients, so they know what the possibilities are, and then you can start to work with it. You can start to see if there are ways to kind of stimulate that intellectual desire. There might not be the physical desire, but there still might be the intellectual desire or the emotional desire there to be close, and then other ways of engaging intimately with your partner. Maybe intercourse is off the table, but outer course is on the table. Maybe it's more about physical touch. Maybe there are all kinds of ways to experience intimacy with your partner and feel that pleasure and that joy and that connection and that satisfaction, or with yourself as well.
And as we wrap up, I'd love to just give each of you an opportunity to provide one or two takeaways that you would like our audience to walk away with today, just as a nice little wrap up.
I would just like to say, let's correct the system that we all came up through, and let's go out and let's seek the training that we're not getting in graduate school. It's important to include sexual health. It's important to include, their experience as a sexual being in the session, and it is helpful for them. It's helpful for you. It makes you a better therapist. Please go out there and get the training that you need so that you feel comfortable doing some of this work.
I would just like to say thank you to Sasha for helping organize this, and definitely thank ADAA for having this idea and bringing it to fruition and inviting us, and we just hope to continue the process. Thank you.
I'd like to encourage everybody to make it a routine part of their assessment to ask clients about the role and experience of sexuality in their lives, so that even for the majority for whom it's not a problem, you're giving the message that it's a safe subject to talk about here in case it ever becomes a problem.
Yeah, these are great takeaways. I would just add that it's not too late to get the training that you might have missed in graduate school. Would echo the great advice about asking for, but really even demanding it. So you could go back to your graduate program that you graduated from and say, I am disappointed we didn't have this part of our training. Please include it in future therapist training. But there's so much available out there. Please be in touch with me if I can help at all with any of your training needs.
Thank you everyone for joining. Thank you to our audience and our wonderful panelists. We invite you to continue learning on ADA's website, attending additional sessions. And we hope to see everyone at the ADA 2024 conference in Boston in April. Submissions are open now. So if you'd like to continue this conversation, we invite all of our attendees and our wonderful panelists. Thank you so much.